Welcome to Sirens Stethoscopes. I'm your host, Kevin. This is going to be our new podcast where we take concepts from all over medicine and we apply them to our clinical practice to be the best EMS providers that we can be. The concept may seem familiar to you from our other podcast, Outside the Box. That podcast will continue, but we're going to dedicate that platform exclusively to other things around clinical practice and medicine that help us be the best providers we can be. So we'll talk about leadership and personal development and education to help enhance the way we do what we do, so that here we can focus on medicine and clinical practice. And with that, I think we're ready to get started into this first episode that we have dedicated to a very special population of people that we take care of with a concept we've dubbed Mayday Medicine. So let's get into it. So welcome. Thanks for joining us today as we talk about some medical problems, some clinical issues that come up when we rescue down firefighters. I am joined today by Bo and Gene, some of our very own who have a lot of good experience in the way we've been developing how we handle these situations, contributing to a more regional response to it. And they're here today to help us take this to the next level as we talk about treating the medical problems, the resuscitation of these firefighters. Guys, thanks for joining me.
Thanks for having us.
Thanks for having us.
But why don't we come down to the end of the table? Why don't you tell us a little bit about you and some of your background?
All right, so I've been with Sugarland for a little over 5.5 years, right around 5.5 years. I've been in the service in total a little over 9 years. Loving every minute of it. Both my parents were paramedics, so I kind of had the natural affinity just to fall into this role. Yeah.
What's your role been in rolling out this training and delivering this?
So me and Gene were asked to come help with the regional training for the actual Maydays. And we realized kind of then that we have fallen short in getting people to the door. We've done really well in certain aspects and then just stopped. When, we're fire and EMS, we can't just stop at the door and be like, all right, that's good. We need to, get these people out into the grass rather than dropping them at the front door. Because, even, we've both taught at the academy, and it's just like, how many classes have we taught it's acceptable to drop either like the downed firefighter or just a victim right there at the door?
Right there at the door, yeah.
And it was kind of a dumbfounding moment when we realized, hey, we still got some stuff to do. And then even if it's a downed firefighter, it may be a little bit easier to move a victim if they're not in gear, wearing metal and everything. But I know if we're not the EMS taking care of them, someone else would still want to be there, but they don't have breathing apparatus to grab them from right there. If they try to grab them and they're grabbing buckles and all they're wearing is latex gloves, then that's not going to bend very well for them. So
excellent. Gene, why don't you tell us about you?
Sure. Been with this city for 10 years, 17 total career. Was fortunate enough to start with Community Volunteer Fire Department. Was picked up by Richmond Fire Department after that. Did a little part-time with Fulshire and Pecan Grove. Worked at the Fire Academy, which was an awesome experience. And started slowly being asked to help out with, training, which I love participating in. And then for some reason, search and rescue and Mayday training really stuck. It's been the bulk of what we've been doing. And then Bo and I started working together. And we noticed that training scar that he was referring to about pretty much just the dummy goes out the window, and then that's it. Don't take the dummy too far because we got to put it back in the house. So we realized there was a need there, and we've been slowly trying to bring it together.
Yeah, absolutely. I think back to my academy days. I got hired on another fire department, sent back through the academy, did our own in-house one. So twice I had the same experience of just what you guys described, that we're going to practice rescue. We're going to do the Denver drill. We're going to do all the rest of these other things of getting somebody out of a basement, because that's the Midwest and we got basements. Yeah. But it was the same thing. We break the threshold, good, put them down, go back in. We got to search some more. We got to do something else. Or even, like you said, just put them there because that mannequin's got to go back inside. Right. So let's not do
that was
too
the
much.
Biggest one.
Yeah.
Right. And I feel like in the last couple of years we've made advances as an industry away from that. And that was part of the training y'all developed is we've continued some of that care past the rescue. We started CPR on these firefighters in gear and developed some good methodical techniques to get them out of gear. And that's what brings us today, really. We have done that, and what we saw out at the training ground with some of the drills is we're good at getting the people out of the gear and then shifting gears into the resuscitation and the medicine we need to apply. Wasn't that smooth, and it was kind of a challenge to go from this search, rescue, Mayday operations mindset into a clinical mindset. And that was a difficult shift for some people.
Yeah, that's new. That's new for us as an organization. That uncharted territory is something that, again, another observation, another gear that we need to start focusing on, and we're excited to help out in any way we can.
I mean, here we are.
Yeah.
And but why don't you tell us just a little bit, like recap some of this CPR in gear? Can you describe some of that for us?
So the CPR and gear, Gene actually helped develop at Threes. They noticed a big lacking in organized structure. So they ran that little course over at Threes. Everyone kind of ran through it, and then he kind of reintroduced me to it. It's one of those things that, like, I could probably do it if I needed to, but teaching, I don't know how many hundreds of people that we had come through in that training, it was like, hey, let's go over this again. And now any new hire class we've sat there and gone through, because it's something that we don't teach at the academy currently. I'd like to be able to actually, get that in there, but it's just different. Just because the way you do everything, it's very hectic when a firefighter goes down in general.
Yeah.
But sitting there having Fort Bend County EMS run 90% of the surrounding area, besides Sugar Land in Fort Bend County, like they may have either previous history of working at a fire department, which I feel like firefighter CPR in the gear removal aspect is pretty new, or volunteer experience somewhere, which they may or may not have had formal training of that thing. So pushing it out here, making sure that all the firefighters know it, because if I want to be there for somebody, like I want to be there for my brother, and that's pretty much kind of why we're setting that precedent of like why we do it, why we're doing it this way, is because you're gonna be there for that person.
I agree with you 100% that you're right. Going to be crazy because everybody wants to solve this problem, and this is a great opportunity that we give some people something to do. We give you some product to produce. Because this is a 3-person evolution. I mean, the rescue's going to happen. Probably going to be more. It should be more than 2 people. Hopefully, if we're doing it right. But this is 3 people to get compressions started, getting this person undressed, and get moving through. And you alluded to it a little bit, Bo, that we have single role agencies around us. That there's ones that do exclusively EMS. There's ones that do exclusively fire and rescue, and work together to meet the whole need. And we're kind of in a unique position here that we do both. We have the dual role kind of stuff. So I see that as making us the leader in this, of bridging the gap between what we've been practicing and what we're going to talk about today. But who better than firefighters to navigate gear, right? And like you said, with things being hot, metal's going to be hot. I mean, even at a 400-degree room, man, things get up to 300, 400 degrees, and you start touching them. I mean, think about you pull the cookie sheet out of the oven without the oven mitt. Yeah, you're going to do it once, right? Yep. So you're right. Even with some previous experience of other agencies where a clinical provider may be working at that moment, may not even have the PPE to properly get this person undressed without doing themselves some real harm. So we're in a great spot of it. We start this care, and I think we all know in CPR that compressions there are paramount. And this gets us immediate compression. We're doing compressions before somebody's undressed. This isn't get them undressed, do compressions. This is do compressions, then get them undressed.
Anywhere between 10 and 15 seconds, we're starting compressions.
Right, and I think it's fabulous because, I mean, that's what's going to count. Right. Cool. So let's talk about this. Let's talk about some of the medicine. This is the worst kind of situation we could be dealing with. This is the most challenging circumstances. Job's physically demanding. It's taxing. Very good chance we're tired from whatever else we were doing in the day. I mean, chasing y'all down to get in here today from what you were doing out on calls, and this is day 1 of the tour. All these factors going into it, right? And then you add in the stress of this person. If I got to fix this, I got to do something. And man, does those cortisol level goes up, stress goes up, the clear thinking just starts coming down. It becomes a real challenge, right? what are some things, as we talk about this and some treatments, we're going to talk about what will kill somebody, what's going to kill a firefighter, right? And I'm going to start with this one because taking care of our health and our wellness is a crucial thing, that we got a lot of cardiac-related deaths from firefighters. And that's why up to 24 hours later can still be attributed to a line-of-duty thing. I'm not telling you guys anything you don't know. But just the heat we absorb, plus the exertion we put out in the gear that we have, like that's, I always thought it was amusing that we're like, oh, make things safe. We got to make our jobs safe. And I think we're going to go into a room that's several hundred degrees. But to protect ourselves, we're going to use gear that doesn't allow moisture to pass back and forth. But our body sweats to cool off. But the gear says, no, you don't get to sweat. I'm going to hold it all in, and negates our natural cooling mechanisms. So safe. Like take safe and throw it. Like it's not safe, right? Like, nothing we do is safe. I used to tell people, if you want to stay safe in this job, just like hole up in the basement. It's about the safest thing you can do. I mean, driving to work is dangerous enough. But we get these cardiac events. And really the best way we're going to approach those is our standard cardiac arrest management, right? I think that's the easy one. I took it, low-hanging fruit. We'll talk about that one first. But we do. It's very likely we could get these cardiac-related events taking firefighters down.
Yeah.
So
I'm glad you brought it up, just because every time you try a Mayday scenario, like one of the big things that we do, another training scar, is anytime you remove a downed firefighter, even if their mask is intact, we sit there, and what is the first drug that we always pull? It is the cyanide. It's because it's just been drilled in us. It's like, hey, you need to have this. It's like, hey, his mask was still fully intact. He was breathing air. He just went down for an unknown event. That's probably not what we actually need to push. So, like, thank you for actually going into just normal, normal cardiac arrest stuff rather than.
Well, even before that, the damage is being done well before the call. Sleep deprivation, high cholesterol, hypertension. If we're still smoking, drinking off duty, in varying amounts. Of course, the stress of multiple calls, it all adds up. And then when you tack on training or the fire, increased heart rate, dehydration. Dehydration is probably the big one of the bigger ones.
Big one, right? Yeah. I mean, we show up and start drinking coffee, start drinking energy drinks.
Exactly, yeah.
And I mean, honestly, that's where we solve the world's problems, right? As drinking coffee around the table in the morning. The world needs us to do that. But right, it goes right into dehydration. You're absolutely right. Like, the first thing we start doing is things that suck water out.
So it ends up turning into like a recipe for disaster.
Yeah. Oh, and Bo, you make a really good point that we're going to talk about a couple of these, and it's a very good differentiation of this mask is on and intact, or this mask is. It could be a list of things not on and intact. So it is working or it's not. Mask is off, mask is damaged, seal's broken, whatever it may be. Just not working in that fashion. And I think that's where it complicates things. That if the mask is on and intact, hopefully there's some air still in this bottle, didn't run out, that prevents us from hitting into a couple other problems. But then it's really pretty standard. Once we get this person out of gear, that's the bread and butter that we know. That's the standard cardiac arrest management, right? And even if this person has sucked their bottle dry, that they lose consciousness beforehand, whatever it is, and the bottle just runs dry, we've done with suffocations before. We've done with asphyxiations, right? Still more challenging, still a very unfortunate circumstance to deal with. But again, that's not unique to a fire, right? So we know how to do those things. But we're going to talk about some of the specific things to fire.
Sure.
Let's talk about trauma, though. Let's talk about how trauma comes into firefighting and gets us in trouble with downed firefighters. Gene, why don't you talk a little bit about some of that?
Trauma. So when we were in the previous classes, we've really been hammering on a good assessment of the downed firefighter. So we talk about, finding an area of refuge, close the door, open a window, start clearing out that room. We're not creating a flow path. And then from there, we like to have that firefighter right in front of us. That way we know their gear is situated the same ours is. And then we just start a head-to-toe assessment. The first thing that's coming off is that helmet, putting our hand in front of the regulator to see if it's been displaced from any fall, maybe fall into a floor or something like that. We want to make sure the regulator's in place, kind of doing a little bit of sweep on that mask to make sure it's also where it needs to be. And we go from there. We go from there with the straps. But as far as the trauma,
I think that's one thing that we just kind of overlook is it's so hard to sit there and make a down firefighter that like roof collapse all the time. Most of the ones that I can say I've been in at least have been small chunks of ceiling stuff come in, like you have a box of I've had Christmas trees fall out of the attic because it gets hot, degrades, stuff starts to come down. I haven't had a AC unit fall on me. That's one of the things that definite firefighter killer. If it falls just right, it can sit there, break the neck, and we're not going to get that person back. But
we're also not able to roll them over, check C-spine, C-collar, things like that.
Yeah, trying to move a 2-ton unit, it's just not going to happen. So that's one of those things we go into like a little bit more pre-planning for. But
it just goes back to like a solid assessment, which is what we're showing them, and then from there, it's out. And like we said, the firefighter CPR. As far as getting them out of their gear, it doesn't even have to be a CPR yet at this point. We just need to get them out of their gear so that we can do that assessment and find out, are there any broken bones? Is there anything that needs to be mitigated immediately?
Yeah. And we kind of go on to that presumption that there is no pulse until we can find a pulse. Right? Which better to err that side than the other. But you're right, but like we get small chunks of material coming at you. You can get big chunks of material coming at you. You can come through the floor, like you mentioned. Like we could run the gamut of high acuity trauma from a hypovolemic state because we've punctured skin, we're bleeding out, whatever it may be, all the way to maybe even more of an obstructive state that we come through a floor, we have a pneumothorax going on, and it just interferes with normal physiology, and now we have this shock state that the body can't overcome and compensate for. And really, I mean, we don't know that till we really get them undressed. We get to the ambulance. That's going to be a difficult thing to find for a little bit.
And piggybacking off that shock state, another one that we've been talking about it is we assume this gear is just going to come off based on the uptown, midtown, and downtown that we'll get into later. But just assuming it's going to come off, we have not talked about full thickness burn, not being able to get the gear off, and what goes from there. Because what I understand, I think they said Parkland formula is kind of going away.
Yeah, kind of going out.
Yeah, so we still need to hit it from that aspect.
That is true, and we didn't even put burns on the list as something we're really talking about today, but that's clearly should be a very large concern when dealing with fire.
It's an evolving conversation that we, like you said, we just talked about this on our last one. We're like, hey, how are we getting this gear off? We've talked about, what were those shears?
The 1X shears, and then I think Richmond was. I think we had talked to Richmond, and one of the guys was going to buy something. They had a little bit of money left over in their training thing.
Yeah,
and it's for cutting gear.
It's not ambulance shears.
Yeah, let's be clear. Trauma shears aren't going to cut. Like,
no, they're not. It's going to take forever.
At all.
Right.
Don't do that.
You're absolutely right, though. You're right. We kind of take that for granted. That in our training situations, we think we're stepping ahead because this gear comes off. Even then, even in training, we realize just how difficult it is with being sweaty, that if we don't have a hold of it the right way, those liners start to stick. And But you're right, we start dealing with burns. Man, it's a whole nother conversation, Gene. You just threw a curveball right in there. I like it.
No, that's good that we were broaching the conversation.
Yeah, but you're right. I mean, burns could easily put us in that arrest state and drive some very specific resuscitation decisions. What are you saying there, Bob?
I will say, with the trauma, going back to the trauma, like one thing, like Chip and Joanna Gaines, right? They made natural light like the thing again. And what did that come with? Long headers. They have been coming down more and more frequently. You get that,
those engineered beams,
engineered beams, 4x8s that just run, 16 foot through a thing.
You introduce heat to them, and
right, we have a lot of engineering that holds up great.
Perfectly.
Until it's hot.
Yeah,
exactly.
Right. That was, I don't know, man. Maybe a couple of years in, we started thinking of that. That I was out in our rural communities where I started, volunteer fire department out there. A lot of old farmhouses, solid wood, right? A lot of good balloon frame kind of stuff, and you knew what you were dealing with. And then construction just blew up, like it's been around here for years now, and just those houses went up. And we'd go look at these houses, and like, there's no way this thing will even stay up without a fire. Looking at how some of these beams are, looking at how some of these boards, and you're right. I mean, it's glue. It's sawdust and glue packed together, You heat up the glue and there it goes.
But it's heavy when it hits your chest.
Yeah, I believe it. Brian, I haven't been hit by that before.
Oh, I haven't either, but I'm saying,
Okay.
like, that's one of those things that if you get pinned by one of those, it's like going to, like, a trauma thing. If you have one of those, then you have to remove that beam before even starting your assessment.
We haven't gotten to the rescue yet.
So,
We're still
yeah.
getting to access. All right, so let's dive into a couple things that we need to worry about if we get to this person, this mask is off. Well, crap. This device designed to protect us from this toxic environment has been compromised. Dang.
All right.
Right? So let's pick one of these concerns.
So, right off the bat, RIT team, not the most favorable position to be in, but you need to take it serious. So you bring out everything that you need. You need to be active RIT. You need to be looking at the building. Don't just put yourself in one spot. Of course, crew integrity, you want to stay together. But like, start listening to the radio traffic. You know, what do we have? Where did they come in from? Where could they possibly be? Where did they say that they are? We'd like to have someone on that Scott RIT pack, that large Scott RIT pack, dedicated person to that. They have it set up the way they want it, whether the bottle's on or off. There's a huge conversation going on the floor. Bottle on, bottle off. Mask connected, mask not connected, all this stuff. And there's good points on either side. But it all boils down to when you're put on the Scott RIT pack, that's your duty. However you're going to bring it in, when we say we have a down firefighter, move up, that's you, bud. That's your time to shine. Okay, and that goes back to all those little things, those little wins. Having the mask with the net already pulled back, that we weren't having to mess with it. Some people have it to where the hose is disconnected. I personally don't like that. The last thing I want to do is have to mess with that hose in a low zero vis environment. So yeah, just taking it serious, taking that job very serious.
Nice.
Yeah.
I'll say it can even go a step further back than that, because you do have your RIT teams, which should ultimately be getting that guy out. But a lot of the times, like if I'm inside of a structure and I'm doing search or I'm doing something, or especially if I'm fire attack, and I hear that somebody went down, I'm going to want to go help. Yeah. But, like, you need to keep a level head, and if you're doing something that you were assigned to do, make sure to keep that fire in check, because the last thing you need is that fire to grow and then affect other people. But if they're like, all right, hey, your search, and we already got the all clear, or you're secondary and something happens, then if you get reassigned to go assist in finding that, you may not have a RIT pack. Like, if I go in for a search, I'm not carrying in a RIT pack, right? But if I find that guy first, knowing to get that person to a not ideal
area of refuge.
Yeah, area of refuge, right? Like, get them to that room, isolate, be like, hey, this is where I think I am. I'm breaking out a window. I'm isolated in here. Start making that better if they don't have a mask.
That's what we hit on big on the in the training is, it's a house. It's a bunch of boxes inside of a large box. Get inside of a box. Get inside of a room. Make sure it's not the room area origin where the fire's at, and shut that door. And let's start working on a plan. If you got enough people, find me an exit. Somebody find me an exit, and then the other firefighters doing that assessment. And again, the biggest thing is making sure his mask is intact, making sure that he's breathing air, and all that can be done when you have him propped right in front of you.
Yeah. And what are these toxic products of combustion that we're trying to fight against?
Yeah.
All of this is to fight off a couple terrible enemies that we have here.
Yeah. So cyanide, carbon monoxide, benzene, phosgene. There's a slew of chemicals and stuff in the air.
Right. I mean, for instance, what plastic now? Right. Whatever synthetic materials we've made it out of, and these chemicals break down under heat, and they make some not nice.
Yeah, and you start breathing that in, and they're all fighting each other to basically asphyxiate you.
Yeah. Let's talk about. We'll talk about the asphyxiation part, right? We talked about kind of this suffocation, and let's talk about cellular asphyxiation, because you mentioned cyanide, you mentioned asphyxiation. Let's tie these things together. How does cyanide? How does that tie together? How's cyanide going to kill us?
Well, it binds. I think it has an affinity like 250 times more than oxygen. I believe.
We're talking about carbon monoxide. Then.
Oh, carbon monoxide.
Yeah.
Okay. Yeah.
So if we talk about cyanide, we're talking about a metabolism problem, right? It's really what we get to. To get really nerdy, This affects the Krebs cycle. Look it up, guys. I'm kidding. I don't know the Krebs cycle. Right? What I understand of the Krebs cycle is that sugar comes in, gets used, makes waste product. Waste product kind of gets recycled. Some gets recycled, some gets eliminated, and the life goes on. Yeah. Right? Cyanide shuts that down. It's like, nope, we're not going to do that. It inhibits the cell's ability to use oxygen as a fuel source, which the cell's got a backup fuel source, right? But what are we going to use instead of oxygen? If we start using anaerobic respiration, what really becomes our fuel source?
Oh, if we run out of oxygen?
Yeah.
We're just going to start using glucose, if I'm not wrong. We're just going to start burning through everything.
That's our dirty sugar. Or I'm sorry, our dirty fuel, right? But if we disrupt this whole cycle, our waste product coming out of sugar doesn't get recycled, doesn't get put back in, we just become acidotic. We just become really toxic with it. And interestingly enough, looking through it, cyanide, it contributes to pulmonary vascular vasodilation in an extensive way, because the enzymes that would help maintain vasoconstriction, cyanide shuts them down. So we lose vascular tone, we lose pressure in that pulmonary trunk, and now we just don't even have anything to exchange and to move through. So what do we do about it, though?
Oxygen, treat with oxygen. It's the Cyano kit, which we've been preaching, but of course making sure we're using it for the right reasons. Educating ourselves on the Cyano kit, which I probably need to go educate myself in the Krebs cycle. Like I said, it's probably not our strong suit.
It's something everybody loves, man. I mean, you don't talk about that like with your wife over drinking?
Absolutely not.
Yeah. No, don't worry, I don't either. Yeah. I mean, she already calls me a nerd. I don't need to do that. But, right. The interesting thing about the Cyano kit, I mean, it's really expensive. It's worth the expense. You'll know what it turns cyanide into?
B12.
A dang vitamin.
Yeah.
Right? Like it produces V12 in the body. And body's like, I know this stuff. I know how to pee that out.
Yeah.
Right? I mean, you got red pee for a while.
Yeah.
Hopefully you're peeing and you get red pee for a while. But right, like that just blows my mind. Here's this massive toxic exposure. Just give him some vitamins. Like, it sounds so like hokey.
Yeah.
Yeah, give him some get some oils on it too. We get like a Himalayan rock and see if that helps. Like, like all these
with burn some sage.
Right. I'm like, friggin' B12. Okay, right, B12. The other thing is, like you mentioned, this oxygenation is a huge part of it, because these cells are deprived of oxygen. They're just starved.
Yeah.
Right? So we can knock the cyanide out. That's cool. We need to maximize the oxygen that's available and get back to it. So, but yeah, and you had mentioned even carbon dioxide, but why don't you take us through carbon dioxide? What makes this a bad news bear?
So that is the one that's going to sit there and bond a little bit higher than everything, and kind of just, when everything is binding, it binds faster, it binds better. If you're going to sit there and try to breathe with that, it's not going to work well. Unfortunately, one of the things that a lot of monitors that we use, they will still read 100%. So that's one of those things, like, you have to make sure that your providers are prepped and knowledgeable about, hey, yeah, let me check his O2 sat. It's like, oh, that's actually good. When 100 is reading, 100% binded, not 100% of oxygenation.
And this doesn't have to always be in a IDLH environment. This can happen in overhaul.
Yeah.
Extended overhaul.
It's probably more likely to happen in overhaul, honestly, that it's, I think we're getting better as an industry. We love to pick on the new guy for wearing their mask, wearing their Scott with for overhaul, and like, what a loser. But that's actually probably the smartest kid in the room.
Yeah, ego plays a huge part of that.
Yeah, he may not look as cool as the old guy standing there with the cigar smoking during overhaul, but he might live longer than us.
Right. I mean, we do it. Like, and I've been guilty of it. I little proud of myself that I turned it around a little bit and started overhauling with proper PPE. But when I started, we'd do that. You'd be sucking the stuff in, whatever. I did investigations for a while, so the same kind of thing. You'd be in there trying to do reconstruction pretty quickly after this without properly ventilated. Yeah. And then, man, my head hurts for 3 days after I came home from work, and no crap. What a surprise that there's carbon monoxide in there. Your brain's hypoxic, still fighting this oxygen. Of course it would be. And what's our solution, though? What do we do? How are we going to treat this?
Well, as far as solution, one of the things is I've been wearing the air monitor. We're going to these calls. We're doing overhaul, things like that. So I make sure to have that on me. Again, people probably saying, why are you wearing that? But somebody needs to wear it.
Yeah.
At some point, somebody needs to be wearing that. Just good practices is what's going to help us.
I like
out.
good prevention. Prevention's good.
Prevention, yeah, good. Yeah.
So just before I go into treatment of it, there has been more and more cases of drivers on the pump panel that are right at the door, or not at the door, but right at the front of the house, getting carbon monoxide because they're not the ones going in. Mm-hmm. That carbon monoxide lays low, right? Mm-hmm. It doesn't sit there and go up with the other products of combustion. A lot of that stuff is laying low. You sit there and you have high winds. It's pushing it. It may be driven back towards him. He doesn't realize it until it's too late, and he's sitting there. At the end of the fire, you're like, bro, you didn't do any work. Mm-hmm. Like, you may have pulled one line. You're sitting there pulling levers, flipping switches. And he's going down, and they put everything on him. It's like, it's the engineer. It's the guy that, generally in the fire service, engineers are some of the bigger guys. It's like, maybe it's just a cardiac event. Mm-hmm. Well,
or he's out
sit there, or he's just out of shape.
Well, yeah, that's what I'm saying. Yeah. Like, people, that's what people go to rather than like, check his CO levels. Mm-hmm. It's like, it's a little bitty number right under that O2 sat that luckily our monitors have, but that's more and more things. I'm not saying go out there and wear your normal clothes and then wear an air pack, because I would make fun of that guy. But realize what environment you're going to be in. If that stuff is laying down, maybe think about it. Maybe think about, all right, we'll have that next truck that's not right in line with where everything's going, and we'll use that truck. We may have one or two lines deployed off of that. Maybe just move stuff.
He's outside with 7 apparatus, just breathing it all in.
Yeah.
And you make a good point of CO2 being heavier than air and laying low. What do we teach civilians to do in a fire? Right? Get low and go, all that stuff. They're down there in that. Mm-hmm. So this is some good stuff to consider. We're talking about civilians, civilian rescues. Hopefully we get somebody before the thermal damage sets in, a lot of the toxic exposures set in. But carbon dioxide spreads and it lays low. And here we are 3 doors down the hallway from the actual seat of the fire, and this person's getting exposed.
Not even knowing. Can't smell it, can't see it.
And then you're right, we do. We put it on there. SpO2's fine. Things are looking all right. They're just unconscious for some reason. Well, because they're dying. Yeah. Right?
Luckily, we can fix it.
We can. Tell us how.
Oxygen. Eventually, you will start to overcome. Now, it is a slower process. We can speed it up by using, if they are a little bit more coherent, we can use CPAP. With our vents, we can use BiPAP. We can kind of do forced air. Don't be slowed by only putting a non-rebreather. Sit there and put a nasal cannula on and run that at 15 liters a minute. We have multiple oxygen ports for a reason, right? Why not deplete the oxygen of what we have on that truck? We have 2 of the small cylinders, at least. We should have 3. And then we have that big one in there. I doubt anyone is going to be mad if you give all of that oxygen to people that need it. No. Right?
Then you bring that person around when somebody's going to yell at you for using that much oxygen. You bring that patient around and be like, oh, hey.
Yeah, exactly.
Go ahead, yell at me in front of this person. No, I agree 100%. Right? And it's back to nerdy stuff. Laws of physics, that if we increase the volume of oxygen, it's going to diffuse into the bloodstream faster. And if we increase the pressure behind it, it's going to diffuse into the bloodstream faster. And again, don't have to be too nerdy, but these are things we know, and we do this, right? We CPAP, BVM people even before CPAP was in the field, or BVMing people when they need to breathe better. We're putting people on non-rebreathers when they're hypoxic. We just don't know that we're doing this stuff. Mm-hmm. But you're right, we're going to do it to the extreme, because the CO is going to not only inhibit our ability to carry oxygen, disrupts the mitochondria, powerhouse of the cell. That's what I remember from biology, right?
Everybody remembers that. That's the one that stuck.
It's what produces the cellular energy, and CO directly inhibits the mitochondria, so the cells aren't producing energy. So now the body's not getting what it needs. And the interesting thing that we don't often talk about is it sets off the body's inflammatory response. So we get massive inflammation in some delicate places. We get it in the lungs and in the alveoli. We get it in the capillary beds. We get in very small places that are not very tolerant to swelling, to edema. It interferes with more stuff. And interestingly enough, like you said, Bo, we go on this super oxygenation treatment plan, And it reverses all of that. As we start to have that inflammation, we don't need specific treatment for the inflammation or for the mitochondrial dysfunction. We just got to put oxygen in place, and the body just kind of lines it back up. And I like that you mentioned CPAP because, man, I love CPAP for just about anything. Right? Like when I learned it, it was here's pulmonary edema. You use CPAP. Now I'm like, you know, like give it to everybody. Right? Like this person needs some more oxygen, give it to them. That person needs more oxygen, give it to them. Well, that person has pulmonary edema, give it to them too. Like it's just such a versatile thing. And you're right. We talk about this level of consciousness and the safe, quote, safe ways that they're awake and talking to me, and I'll put them on CPAP. There might be some people that aren't fully awake and responsive, but would benefit from this. And really what it is if they're awake enough for CPAP, then CPAP is beneficial on them. If they're not awake for CPAP, you go to a BDM. Right? Like one way or another, pressurizing it's key. And I guess kind of stepping back a couple of times, we're talking about checking the mass, checking the integrity. If we do get somebody who's not breathing on their own but has this air in their bottle, then guys, crack their bypass valve. Like get it cracked open a little bit. Get just the airway filled up with air purely by volume of it, and we're going to get a little bit of exchange. It's going to be the better situation. And when we get outside and start these compressions, as we're getting them out of gear, squeezing and letting the chest recoil is going to expel air and draw air in if there's air to draw in. But if we have a dry mask sucked to their face, because it's on demand of needing to inhale, but this person's not inhaling, take a second, crack that bypass valve and get some air in there.
Absolutely.
But help put off some of this stuff. Man. So I think this is fantastic stuff. Like these are kind of terrifying, really, when you think about what we do. That's my other thing. People are like, oh yeah, I'm not scared of anything. I don't know, man. Like, I'm kind of getting scared somewhere and sucking down some of this air. Like, that would suck.
Terrifying, but also like feeling confident that Sugarland EMS is going to be there. We have the vents, so we can do these things that we're talking about. We're on scene. The best chance possible for this individual is going to be with us there.
I agree. We're going to take good care of them, man. So we talk about these toxic exposure. Talk about reversing them. You mentioned a little bit. We talked about burns and some of the thermal damage. I mean, let's not forget about thermal damage in the airway. That what's going to produce cyanide and CO and all the benzene? Like, where does that live?
Process combustion, incomplete process combustion. Yeah.
Right. Like, so it's smoke. And even at the coolest, we might even be looking at 150, 200 degrees, depending on how far the smoke travels. Like, it's still going to be warm, right? From the Midwest, where we actually had winter. So as an adjustment for me, moving to Houston, step out the door on one of these summer days where it's 120 degree heat index, and it just like kind of catches me. I'm like, ooh, I need to coach myself through breathing this. And that's like 120 degrees, and it's moist air on top of it, right? So we get 150, 200, 300 degree air, one gulp, man, like full of cyanide, you're full of CO. You burn up this airway, which the response to burns is more swelling and edema to protect it. There goes that clenching down.
Dry burns, wet burns.
You get dry and wet, and depending how far down this gets, remember, I love talking about the alveoli because they need a champion. They are so little and dainty and delicate. 200 degrees in the alveoli, oh, they're done.
Yeah.
Like, you're done. And then you're not exchanging gas there probably ever again.
Yeah.
You know? So it's a very delicate balance, and it kind of makes the point that does cyanide and thermal inhalation burns and CO, do these exist on their own? Or are we looking at all of them really come together? Right?
They have the potential to all of them, come together for sure.
So
I'd say they're generally found more together than apart. But yeah, I mean, either or. Like, you're gonna have one, if not all.
Yeah, this is kind of like we come through school and we learn a treatment algorithm. That's where we start, and then at some point we transition over to you don't get to stay in a lane. Like, that was Dr. Humphrey's thing, that human beings have like the God-given right to have as many ailments as they want in one given moment. It's the same kind of thing that it's, well, I'm going to treat CO poisoning. Like, okay, well, you're missing things. Oh, well, I'm going to treat just the cyanide. Okay, well, you didn't treat these other things. So very readily, we need to be prepared for like a multi-pronged approach on therapy, right? So, well, cool, man. Let's talk about a couple little points to tie this together, because we talked about some high-level treatment decisions, some rescue implications. Let's talk about vascular access in these people. Getting out of gear is going to take a little while. Getting set up is going to get going for a little bit. What do you think I'm going to tell you about vascular access?
Humoral IO.
Oh, man, you've listened to me talk before, haven't you?
And I actually was never a huge fan until I went to the cadaver lab and I could see that vein engorged when they pushed the fluid. I was like, that is working immediately.
I'm a huge fan of humoral head. The likelihood of an IV. What do you think the likelihood of an IV is, Bo? Anecdotally, what do you think?
It's not great. I mean, like you said, we walk into the firehouse. What do we start drinking immediately in the morning? Coffee. And I guarantee you, I'm not sitting there getting a cup of water after 5 EMS runs or 5 fire alarms, right? I'm grabbing another cup of coffee because I have to sit there and I have to focus while doing reports. Water doesn't make me focus.
EMS break room, Cokes.
Yeah,
It's true.
It's just we're not setting ourselves up for success. So you're going to sit there, you're going to do that, and then you're going to put me in gear that I'm going to sit there and just pour sweat out, even after like not doing anything. Even if I'm just writ and standing out in the yard, I guarantee you, especially in the middle of summer, I take that stuff off. I'm going to be soaking wet, right? So you're already dehydrating yourself even more. The body is shunting. The veins out here are starting to close down. You're not going to get very good vascular access.
Yeah.
It's just not going to happen.
Yeah.
I would say don't even look. Like, come on.
Yeah.
Right? One humoral head IO?
I'll go both.
Both, man.
Why not?
Like,
We
right?
got 2 arms.
We got 2 arms. We got other areas.
Plenty of people on scene wanting to help out.
You think about this, right? So let's kind of tie this back together. We get this person whose mask was compromised, and I said I wasn't sure if I was going to soapbox. I'll do my little bit of soapbox that if somebody's mask comes off in a fire, it's not a conscious choice, right? Like, this isn't a, you know what? Let's see how it goes. I know better than the fire. This is primal instinct survival kind of stuff that either what's the melting point on our mass? 435, 450.
We just took that,
425
before something.
and that's with the new high temperature mask.
Okay, so the new hounds, right? Less than 500 degrees, right? And 500 degrees kind of sounds a lot when we're making pizza in the oven. It's the high end of an oven, but not outrageous for a fire. Like 500, 600, that's not outrageous. So prolonged exposure there, where this mask gets hot against your face, like that's just your reaction. I'm gonna get this thing off my face. If you get into one of these spots where the air you start breathing is hot, I mean, that takes a good amount. That you have compressed air expanding should be nice and cool coming into your face. But when it's not, really, I think 100, 110 degree air, you start to feel this difference because that's a little bit higher than your body temperature. Again, you take a breath and it hurts. You're going to rip this thing off your face. So let's not pretend that this is some bad decision-making process. This is somebody who has hit the end of the survival road and is not thinking. Yes, absolutely. This is panic physiology. This is survival decision-making. So let me take a moment to soapbox on that one. This is not because somebody's a bad firefighter, bad person. No, this is because they were in that much trouble and that scared and that panic, right? So let's go back to it. This person has a mask that's compromised. They take a gulp of this. We got the cyano kit going in an IO. Talked about dehydration. So let's give them some fluid. It is a cardiac arrest, so there might be some medications we got to deal with, especially if we're dealing with dysrhythmia management. Man, like lines and lines and lines, right? And with the exception of some of the hypovolemic management, like this person can take fluids, right? Like I'm talking a couple liter or 2 of fluids. That's like, right? Let's fill this person up a little bit. Let's get some of it back in the system. Yeah. So I'm a huge fan of humoral head. I'm a big fan of 2 humoral heads. Right? You get some fluid in at that point. We start looking at IV. Sure. We go to the tibia for a 3rd access point. Sure. You know, kind of one of these points that is there too much? Right. Let's get the access. So the cyano kit, side note, is probably going to take a few minutes to run because it is a good 100 milliliters to mix it up and it goes. That's going to take a few minutes. And the time that you need to administer something, you can't really wait a few minutes for this line to clear out. You want to make sure you got that other line going. Cool. We get somebody takes a deep breath. We give them a cyano kit. And we start seeing some improvement in this patient's condition. They come out of a cardiac arrest, but they're still pretty bad shape. They're still nice and bright red, all that stuff. We see all the same things. What are the thoughts on a second cyano kit?
Actually, we should probably get more cyano kits on scene. Because we have one guy down, who's to say there's not another one that's or that we're not going to have another issue down the road, and that he might need one. So
Yeah.
I know we have one in the battalions, the ops. I believe your ride has them.
I'll have one soon. We actually have 2 out there, so every fire should have 4.
Okay, yeah.
And we've been trying to add a county battalion on that they're going to have theirs there. So we're going for it.
Yeah.
Well, we're with
Have them coming.
That, right, because cyano kit goes in the body, and how does it come out? What is it?
Excreted urine.
Right, it's nothing, right? So if we give somebody cyano kit, a second cyano kit that didn't necessarily need a second cyano, they're going to pee red a little bit longer.
Yeah.
Right? B12, right?
And the symptoms for it or the side effects are minimal. Nausea, vomiting, just discomfort type stuff. And
Yeah.
of course, the changing the color of the urine.
I'll gladly take somebody complaining to me about how they were uncomfortable because they survived, then,
Yeah.
the other side. But, well, guys, I'm excited about this stuff. This is mostly because it gets really nerdy, and I'm a huge nerd. And understanding what this stuff does to the body. I appreciate your help taking this from some of the classic ways we used to look at it of, CO poisoning just gets oxygen. No, here's why specific approaches to oxygen are important. Or somebody came out of a fire, they get a cyano kit. No, here's the reasons this person gets a cyano kit and the effects of it. So I appreciate you coming along with me on this nice little journey, nerdy journey, and breaking it down a little bit. Before we wrap up, though, I want to give you a chance to throw any other thoughts in there, anything you didn't get to say about the topic we're talking about today.
No, just that, firefighter CPR, as far as I can tell, the earliest video I could have found was like 8 years ago. And whenever we go to these training events, we'll ask, who's heard of firefighter CPR? And maybe, 3 hands will come up. So we're taking the time to make sure that that's out there. And then also this last regional event, we really took it all the way, like from packaging of the firefighter, bringing them all the way out, well into the yard, and then we even had the ability to have the medic units on scene, and they picked up the firefighter and even had the Lucas on and everything. So next time you do that, make sure there's no batteries in the Lucas, just to be on the safe side. But
it was terrifying. I got to play victim a couple times, and whenever they press start, it was just like, hey, all right, do not press play. If you compress my chest, I will not be a happy camper. End of drill, guys.
Well, we're excited to see the training go from beginning to end. Yeah. And that's where it should go. And then identifying more issues and tackling those as well.
Nice.
Yeah.
Anything else from you, Bo?
So I'll just kind of tack on with what he said. We got to do the regional fire side. Next is maybe that regional EMS side. I know we have EMS here, but like I said, Fort Bend County runs everywhere else, and all the firefighters know how to do it. But what happens when it's one of those rural departments that you're waiting a little bit longer? Is once you get those metal pieces off, who's to say that a paramedic couldn't do Midtown or downtown? Because once you pop that buckle, nothing else should be superheated. And once you pull right here, compressions, it's just normal compressions. But I feel like our EMS area should at least know what's going on in that area. So maybe setting something up that we could get them on the right track. If not necessarily doing it, but knowing why we're doing it, going a little bit more into this kind of stuff. Because, if you're only EMS, you should know how to do EMS really well. You should know how to run a code. You should know how to treat all this. But maybe you step back into our role and why we're doing it this way specifically.
Yeah, I agree. And this is our first step towards driving that. Like I said, we're going to be the leaders of it. We're dual role. We're on both sides of this line, and that's the big push: is to get away from we get out the front door, we stop the front door, I'm out, now you're in. It's your patient. That just doesn't help any of us, and that's the training scar that we're trying to recover from. So we're absolutely at the front end. We're pushing it. We're driving it. So I think the last couple things I'll say, right, that oxygenation, ventilation, pretty dang crucial. There's a couple specific nuances to a couple other things, but really that carries through all of them. That if somebody comes out of a firefighter, civilian, making sure they're oxygenated and they're ventilated is pretty dang crucial. Right. And then there's some other things with it. All right. There's one more I was going to say. Actually, the crowd control. We talked about it with the firefighter CPR, the rescue, the coming out, and we kind of specified 3 people in the uptown, midtown, downtown roles to kind of prevent everybody from throwing hands in and making this chaos. Same kind of thing once we get out of gear. We get them in there, we drag them out, we get pants off, we start delivering this care. It's another opportunity for 6, 7, 8 people to just dive in on this. So attention to how many people we have involved, who's there, who's doing what.
So it's going to take a strong command presence. This is going to be extremely chaotic. Everybody's going to want to get in there. Hopefully, the firefighter CPR training that we've done, it needs to be done just like any other training. And we need to stay on top of it. Otherwise, we're going to revert to just like pulling and prodding and duplication of efforts. So there needs to be a strong command presence. We need to stay on top of the training, and then making sure that it doesn't turn into a mess.
I agree. Well, gentlemen, I really appreciate your time this afternoon. Thanks for coming and sharing your thoughts with us and the experiences.
Thanks for having us.
Yes, sir.
Thanks for joining us, and we'll catch you for the next one.